And today we have a really cool case, which is a dog that a few months ago had a oral fibrosarcoma removed and presented recently with this mass in the kind of the jugular region. And the assumption is that it was a metastasis to a salivary gland. It was biopsied through here, and you can see that there's some cording extending from the mass out through this biopsy tract. So the assumption was that it was metastatic fibrosarcoma to the lymph node, but I just have not seen that happen very often. It can happen in about 20% of cases, but it would be somewhat unusual. And so we did a CT scan. The lungs were clear. The other lymph nodes were clear. And it turns out that this is attached to the salivary gland instead. And so I did an aspirate to confirm, and it has what looks like a salivary gland carcinoma, and so which is a much better prognosis than metastatic cancer to the lymph node. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So I'm just going to excise that whole biopsy tract in one en bloc excision. Can we get our ligation, please? And we've got big Gelpies. I'll take some big Gelpies as well, please. Now, we are in the emergency surgery suite because our soft tissue suite was taken, and so I don't have a big screen TV, so it's going to be difficult for me to read the questions as we go. And so, if I don't answer your questions straight away, I will try to get to them. If I don't get to them during the surgery, I'll go back afterward and make sure I answer them before I stop the live stream. All right, so this is the right salivary gland region. Those. Yeah, thanks. So we're just getting some Gelpi retractors here. Now in this area, we very possibly are going to run into the jugular vein and which branches into the linguofacial and maxillary veins. Any one of those can be sacrificed, so no big deal there. Dog's getting a bit light. Thank you. All right, well, I'm waiting for... So we did not do a biopsy. What we did was CT scan and then an aspirate. And the aspirate confirmed salivary gland as opposed to sarcoma. Salivary carcinoma as opposed to sarcoma. Watch that. Yeah, we're just a bit light here, so we'll give it a minute. Feels like it may have kicked in already. This is a very nice Wiesler or German short-hair pointer? Wiesler. Yeah. They look very similar as far as conformation is concerned. Color not so much. Temperament is similar, I think.
Yeah, I think so.
Both hunting dogs. What we might do is, where's the right angle forcip? Might have you retract on that for me, please, just to give me a little bit more access to the ventral aspect. These are fun cases. The anatomy is interesting, and there are lots of big structures with short names that we have to watch out for. Probably a bit caudal for the facial nerve. jugular vein, carotid artery, vagus sympathetic trunk. Of all of those, probably the most important one would be vagus sympathetic trunk, because of risk of creating megaesophagus and stuff like that. And I have had that happen before with tumors in this area. It was actually a carotid body tumor that was right up behind the pharynx. I think you can probably let go of that. Let's get the other Gelpy in here. There's no advantage to making your incision with the coag except for the fact that it doesn't bleed. There probably is a slight delay in wound healing using the electric cautery as compared to using a sharp blade. One study, I think, showed that the difference was about 6 hours in wound healing. And I'm a bit lazy, but I just really like the bloodless field. Can I get the table up just a little bit, please? Great, thanks. Do you need a stool, Cindy?
I think I might need a stool here.
So these are almost as good as an adrenal gland tumor for me. I do really enjoy them. So going through the platysma muscle here, and we'll see as the deeper we go, the more the tumor will release itself. And luckily, this dog could be a skin donor. For other dogs, he has so much loose skin. I'm trying to get a little bit of a margin. I'm not going to be able to get a huge margin on it. Getting some little cutaneous nerves here, no big deal. I'm up against masseter muscle right there. I will get into the linguofacial vein. That might have been it right there. Let me just grab a thumb forcep. Is that plugged in? Thank you. That's all right. And also I might have you turn the cautery down to 20. I'm getting into some important stuff. If we do remove the salivary gland, which I believe we will, no, should, yeah, self-adapt is great. If I do identify the salivary duct, I will remove it. I think that might be another vein there. That'll be maxillary vein probably. Yeah. Is that suction turning on automatically, or is that your foot?
It's for my foot.
Right, I was like, oh, I thought the ligature was connected to the suction.
Right?
I guess it is connected to the suction through Cindy.
Yeah, I think this is actually much better. Yeah.
You should have told me that it's connected and that it automatically comes on. I would have believed it.
Should have messed with you. Alright. There's a new function.
Yeah. AI controlled suction.
Just have something connected to your head.
Yeah, right.
Yeah.
To go.
So we just got a new algorithm on the ligature machine, and I have to say it's working really well. It's faster than it was before, and it seems to be cauterizing really well. So the suction is connected to both the ligature and the electric cautery. Very impressive.
Impressive.
Not sure what that is. I think it's probably a blood vessel. Okay. Now what is that? So satisfying as those tissue planes kind of just start falling apart there. Probably 2 OPDS, please. Again, I apologize that I'm not answering questions as we go. I don't have the big screen in here, and so I cannot see them. But stay tuned to the end, because I will go back and answer all the questions. How much fun is this? So that looks like salivary gland to me. There's the maxillary vein right there.
Oh,
See that? And the salivary gland is going to sit right between, or right in the bifurcation of the jugular vein into the maxillary and linguofacial veins. So that's definitely salivary gland there, and the tumor is attached right
that's
there.
what you see on CT scan, yeah.
Yeah, so look how cool it is with cautery, how it just kind of separates and falls apart. Doesn't take much to get me excited. Some little nice dissection planes is all it takes.
Yeah.
All right, so that's maxillary vein right there. All right, so what we'll do, see how I can dissect with the cautery right down onto that vein. As long as you're careful. Okay, so let's get our... It's a really nice review of anatomy as well. So look at this. You can see jugular vein right there bifurcating into maxillary and linguofacial veins. Wonder if you guys can see that. I think you can. So, maybe I'll come on the other side. Let's grab that right angle. So going through platysma here. Sorry for my sniffling. See, that's lymph node right there.
Where we put the LP?
Yeah. I see that there's some questions about probably live streaming and where they do it in human hospitals and stuff. And I do find that stuff really interesting, and I will come back and answer those questions. Really tug on that. My son, when he was interviewing for his plastic surgery position, one of the practice questions was, you have a clinician in the hospital that wants to start live streaming surgeries. What do you do? And I think it's policy in their hospital that any kind of live streaming is illegal or is against the rules. Because of patient privacy concerns and that kind of thing. Alright, so this is just going really well. Famous last words. But everything's coming apart really nicely. Some other big veins right down here. Can I get the table up, please? Hi, Kerala, India. I have actually been to Kerala. I did a...
Is that high enough?
Yeah. Really high.
Can we lower it a little bit?
Hey?
Do you need it to lower it
A
a little bit?
little bit.
Oh, never mind. That's good. Yeah, that one.
Yep. Okay, so we're getting down to the point that we're just attached by that salivary gland. And remember that we have the mandibular and then the sublingual gland. The sublingual gland is monostomatic and polystomatic. And because we're not doing this for the salivary mucocele, I'm not that as concerned about making sure that we get every last bit of salivary gland tissue, but that's salivary gland sitting right there. So I'll have you retract on that. Can I get my needle probe, please? Is it possible the table's coming up a bit? You weren't leaning on the...
No.
Okay. My imagination. Thank you. So I've got my little needle probe here. And I'll bend the tip of that into a little L shaped, like that. This is just really nice for dissecting soft tissue. I graduated from vet school in 1990. It's pretty scary, 35 years ago. I've loved almost every minute of it. Although I have to say that right now is probably a high point in my career. Just low stress, great team, easy to get along with, and I'm not a practice owner. So life is easy. When I finish surgery, I can go home and enjoy my family. Yeah. And I also have to say that I'm not attempting the crazy cancer surgeries and stuff that I used to. I've become a little bit more actually a lot more selective with what I do, rather than trying to be a hero. So that's mandibular salivary gland right there, and you can see it traveling underneath the digastricus muscle, which is right there. So that's digastricus there, masseter, and then the ramus of the mandible is right there. So really nice anatomy review. A few little big blood vessels there. I am loving this new algorithm on the ligation. All right, so we're almost to the point that we can transect, because again, I'm not as concerned, because we're not doing this for a salivary mucocele. I'm not as concerned about getting a huge, getting every little bit of the salivary tissue. Okay, so hopefully you guys can see that. So no, I don't need to worry about, as long as I ligate the salivary duct, I don't need to worry about leaving anything behind. And creating well, it won't create a fistula, but it might create a mucocele. That being said, the literature has shown that you cannot create, we may be getting a bit light. That's the medial retropharyngeal lymph node right there. Feel that?
Oh, this one?
Yeah.
Long.
Yeah. So that's medial retropharyngeal lymph node. That's digastricus muscle there, masseter muscle right there. Salivary, so this is the sublingual, that's monostomatic portion of the, this is mandibular, monostomatic portion of the sublingual.
Such a nice view.
Of course. All right, let's grab the right angle forcip here. Release that, please. Okay. All right, so what I'll do, I might just transect that with ligation. Do we have some 2O PDS, please? Okay. So I've got a right angle around that salivary duct. Lift up that right angle, please, for me, and then you're going to help me out getting this around the tips. So just tips up to the ceiling. Yep. Okay, release slowly, please. Yeah, great. Yep. Okay, so I've just tied off that, not very effectively. So what I'm going to do is I'm going to pull that out and just do a stick tie onto, let's get a scissor, please.
Try a step
Okay, so what I'll do is I'll pull that out, try to identify that vessel. Where's the right angle forceps, please? Okay. I think I may just have to ligation it. Okay, and we'll just let that go back in there. All right, so review of a little bit of anatomy: digastricus muscle, masseter muscle, monostomatic portion or portion of the sublingual salivary gland. We've got facial vein here, maxillary vein up there, jugular vein is down here. All right, so now I'm not going to close my masseter to digastricus because those are two muscles that are meant to work independently. A little bit of dead space here. Let's see how much skin we've got. Should have plenty. I'm going to try not to use a drain. I'm going to try to close my dead space rather than putting a drain in here. Let's see what I can do to get some dead space close. I'm suturing down to my digastricus muscle here. Pick up some fat here. Just have to be a bit careful not to occlude the airway by putting too much kind of constricting pressure on it. Also, by closing dead space, I'm reducing the tension on the skin as well. So I pretty much avoid using a drain in every case unless it's absolutely necessary. So I've gotten the maxillary vein right there, of course. Just come around that side of it. Pick up some epaxial muscle, bit of connective tissue. So that's a great result for this dog, that it was salivary gland instead of metastatic fibrosarcoma. Trying to avoid picking up veins. Invariably, you spend all this time doing a really careful dissection, trying to avoid bleeding, like we hadn't had a drop of blood until the end. And then always happens, yeah. I've got a great case coming in on Wednesday, which I think is going to be an amputation and then a nerve root tumor in the suprascapular nerve that's going into the spinal canal. And I'm going to try to live stream that one if I can. I might even do electric chemotherapy of the nerve root. Both, please, yeah. Get another 2-0, please. It's like a perfect surgery. Fun, technical, good outcome, quick. Whoops. So this is kind of a superficial sub-Q layer, or subcut layer, where I'm picking up kind of platysma muscle and a little bit of connective tissue. Okay. You happy to finish that up? So just do that layer across there to there, and then an intradermal. All right, so I'm going to have a look. Yeah, I have been really lucky with my career, and I've had a ball. I've worked with really great people. Look, I feel incredibly fortunate in that regard. Anesthetic protocol. This dog is on a ventilator. Is it on a ventilator? No, it's not, because we're in ER. So it's not on a ventilator. It's spontaneously breathing. We have it on 1.5% isoflurane. It was pre-medded with ACE and methadone, and then had an Alfax induction. And then we've been topping it up with doses of Alfax. And any more methadone? No. And then post-operatively, we're going to be, I don't want to do nerve blocks because of all the important nerves in the area, as in I don't want to do a bupivacaine splash block because of all of the important nerves in the area. Sorry, I hit the trolley is why it's jiggling a little bit. And we'll do meloxicam and paracetamol, and then methadone as needed. I'm always using active drains. I haven't used a passive drain in 25 years. So the new algorithm is within the force triad equivalent. It's actually not force triad. It's another company called Rhinovet in China. And I've been testing their machine, and with their new algorithm, I've actually been really happy. So we had to upgrade, we had to install the upgrade ourselves. So selectivity has come from, number one, not feeling like I need to prove anything, having confidence in what I do, but also, just feeling like I guess recognition of the complications that I've had, and just being able to spot a complication before I get into theater rather than as I'm doing it, predicting complications. And, at this stage in my career, there's a saying, distance yourself from failure. I just like doing things that are going to go, well, I like a little bit of a surgical challenge, but again, using my experience to know what's going to go well and what's going to go badly. And so I try to avoid things that are going to have major complications and that kind of thing, and just not feeling again that I need to cut every single case. I know that I made mistakes along the way in my career in cutting things that probably shouldn't have been operated on. So also having a great post-op care team here at the emergency center is wonderful. We work together really closely. There's absolutely no gap. We all work for the same company, so it means that the communication is fantastic. It doesn't matter who gets the credit financially for post-operative care. We just make sure that everything gets done right. Great management as well. Hi, Kolkata. I'm 20 and working on an oil rig, LOL, and you'd never guess that being a vet was a dream of mine, but I absolutely love animals, and I always thought this was very interesting. That's fantastic that you're on an oil rig. I hope things are going well for you, and hopefully you'll get home for the holidays. Hi, China. So I do go with a slightly lower energy on my cautery tip when I switch to that sharp tip. I go from 30 down to 20. But basically, it's just kind of a feel for how it's cutting through the tissue, how well grounded the patient is, how short the fur is, that kind of thing. Hi, Indonesia. Hi, Pakistan. Hi, Virginia Beach, Kerala. Let's see. We do have an internship. We don't have a residency. Cindy is our intern now. I think she finishes in May. We will be looking to hire somebody else. We have a few candidates that have already presented themselves, we'll be announcing for applications coming up in the next few months. Let's see. Suction for ligature, there's no evidence definitively that using cautery and ligature increases the risk of cancer in the operating room personnel, but there are carcinogens in the smoke, and so more and more we are sucking up that smoke and evacuating it from the room. So usually we talk about 2 weeks with these guys, where at that point we're happy for them to return to pretty normal activities. I think their tissue strength probably is about 50% at that point, so as long as they don't go crazy, they're going to be okay. Also note that there's a lot of leeway or backup with live tissue in how much strain it can take. And so in a normal situation, a dog that's just moderately active is not going to really push the biological tissues to their maximum. So salivary gland carcinomas, you basically are doing kind of a marginal excision, maybe 5 millimeters around the whole thing. It's kind of the case with a lot of carcinomas. Anal sac is the same thing. Exception to that would be like intestinal carcinoma. You need to get a huge margin on because they're very invasive. Salivary glands, I don't think of them as being the most invasive tumors. Congratulations, Rick, on finishing exams at James Cook University. And so I usually do my initial incision with a scalpel blade, and then once I get through that skin layer, I'll start using cautery to cut. Hi, Tunisia. Hi, India. Thank you terrible about Bondi Beach. We're all talking about it here and very sad because we thought that Australia was, I won't say immune, but very, very, very likely or unlikely for that kind of thing to happen, and it kind of feels like we've lost our innocence, whereas in the US, there are 1,000 a year or something like that. Yeah, so it's very sad. Hi Philippines, hi Qatar, hi Edmonton, hi Seattle, hi Orlando. I'll just go back to the bottom of the comments. Yeah, or intradermal, please. Hi Scotland. And this dog is an 8-year-old. Sorry, what were you saying?
Are we happy with 2 obedience?
Yes, yeah. 8-year-old German Shorthair Pointer. Sorry, Wiesla, with a mass in the salivary gland, male, neutered. And we'll go ahead and wrap it up there. So thanks a lot for watching. I don't have anything else today to live stream, but hopefully tomorrow we'll have some more to go. Anyway, thanks again. We'll see you again soon.